A very good evening, all of you. Welcome to our 12th session, Case-Based Discussions Made Easy. So I hope you guys are all ready. So let's go ahead with our discussion. Before that, please confirm the audio and video streaming. If you have any issues, do let me know in the comment section. And also, before we start, as you know, the objectives of the session, one of the foremost objectives is to make sure that we're enjoying the process of learning. If learning is not fun, then what's the point in doing it? And secondly, whenever you're attending any live sessions or any discussions from our side, make sure that you have your own customized notes, right? Because this is going to save time and enhance your confidence during your revision phase just before the exam. Okay, so with these objectives in mind, let's go ahead with our discussion. And we have a context and 5 questions with a maximum of 20 marks. I hope you guys are all ready. So before we start, as you know, we have the following courses going on currently at ptbdacademy.com, crash course towards NEET MDS 2022 and Mission 12 batch, 1-year batch towards NEET MDS 2023. You can find all the details on our website, ptbdacademy.com. And as we have initiated this new format from yesterday, from 11th session, we'll start with a wonderful quote. And before that, yes, Tanmay and Rashmi, thank you for your wishes. Yeah, happy Republic Day to all of you. So today's quote, in a very brief manner, let's try to conclude this discussion. Consistency, a mantra to success. So as I keep on reminding, there are 3 mantras: hard work, consistency, and self-belief. Consistency is one of the mantras to success. If you realize the fact that a particular task is important to you, and once you understand that doing or performing that particular task is going to enhance your life, either personally or professionally, then it is something which you have to employ, doing it on a consistent basis, on daily basis. The best example as I can give you, and as you're all very much familiar with, is brushing of teeth. Why do we brush? Because with that activity, we derive so many benefits, isn't it? And once we understand that a particular activity is important, such as brushing, we try our level best to perform that activity almost every day. That is one of the first things we do after waking up early in the morning. And as a consequence, we are rewarded for that consistency with good oral health, which is devoid of halitosis. So likewise, even when it comes to preparation or when it comes to anything in life for that matter, if you're consistent, you are telling yourself that a particular task is very important to you. And once you're sending such a signal to you, to your own life, then everything in the universe conspires in your favor to get things done, which are in line with that particular activity. For example, you're preparing towards entrance. You are consistently allotting quality time almost on daily basis towards preparation. Then the entire universe will conspire in your favor and will grant you all success. If not you, then who else is going to crack entrance if you are consistently working towards the task at hand? It's as simple as that. It's simple or easy to say, but rather very challenging to apply, because if you observe, most of the failures can be attributed to lack of consistency. So how to overcome this lack of this particular feature and how to incorporate this consistency into one's preparation? Before I answer this question, again, let me get back to brushing. How did you incorporate brushing in your life? So what magic have you done to yourself in order to make sure that you're brushing on daily basis? So once you realize that a particular task is important, it has to be habituated. If you can habituate that particular task, then automatically consistency follows, just like how you're brushing. So in order to form a habit, we have previously done this live experiment, 21-day challenge. So you perform a particular task consistently for 21 days, you will convert that particular task into a sort of habit. And once you're habituated to that particular task, it can be preparation, it can be anything for that matter in life. Consistency comes as a natural consequence. And always remember, if you observe any successful person, one of the foremost qualities they possess is the quality of consistency. It can be either a personal activity or it can be professional activity. Consistency is definitely one of the mantras to success. So with these introductory comments, let's go ahead with our context, right? First and foremost, as you can see, we have a particular case or particular context. As you can see, a 58-year-old man complains of severe pain in joints, especially during nighttime, and also in the early morning period. Upon clinical examination, his joints appear red, swollen, warm, and tender. Laboratory investigations reveal the serum uric acid to be rising above the baseline values to 9 milligrams per deciliter, blood urea levels 30 milligrams per deciliter, urinary uric acid almost 3 grams per day compared to the normal baseline of 0.5 to 0.7 grams per day. Urinary pH appears to be acidic. Maybe it can be attributed to uric acid. So observe this particular context carefully, and here are some of the keywords or hints which you have. So as you can see, these case-based or context-based questions, you'll have several hints which will enable you to answer this question as accurately as possible, provided you're carefully going through the keywords and you have some background information related to this question, which comes with practice, which comes with allotting dedicated time towards preparation. So you can see the age of the patient has been highlighted in red, the gender of the patient, chief complaint that is severe pain in joints, especially during nighttime and early morning period. And clinical examination reveals that the joints appear red, swollen, warm, and tender, indicating some kind of inflammation. And laboratory investigations almost are conclusive. You can see elevated serum uric acid, urinary uric acid, and urinary pH dropping to around 4.8. So I see some of you have already given your answers. Very good. Really appreciate your enthusiasm. But before you jump into answers, let's first look at the patient. And even before that, look at this clinical presentation. You can see clearly red, swollen ankle, and also you can see redness swelling in the area of first metatarsophalangeal joint. So this is one of the important features of this particular pathology. So this is a clinical image you have. Now with this background information, let's move ahead. Let's go ahead with our first question. What is the most probable diagnosis? Gout, cellulitis, trauma, osteomyelitis. Yeah, it obviously appears like an acute condition, right? Given the symptoms patient is presenting with. So which one do you think is most probable diagnosis given the lab findings you have? We don't have microbial culture. Microbial culture will also help you eliminate certain options here, but we haven't provided you any microbial culture. But given the information you have, which one do you think is more appropriate answer? Along with the clinical presentation, I even mentioned about involvement of first metatarsophalangeal joint in that particular clinical image. As majority of you have rightly chosen, option A is right answer. Award yourself +4, and you can reveal your scores at the end of the session. So why did you choose gout? Why not cellulitis, trauma, or osteomyelitis? Before we answer that question, I just want you to check out the keywords once again. Severe pain in joints, usually peaking in around 24 hours, especially during nighttime or early morning period. And also there are signs of inflammation upon clinical examination. And laboratory investigations clearly reveal hyperuricemia, even though hyperuricemia doesn't always mean gout, because there are several cases of asymptomatic hyperuricemia patients, according to literature, which is quite interesting. But anyways, we'll get back to that a bit later. So you can see hyperuricemia, urinary uric acid levels increasing and urinary pH dropping as a consequence. Microbial culture reveals negative. With staining and all of those come negative, based on which you can exclude cellulitis, osteomyelitis, etc. But given the classical clinical presentation along with the image, along with lab investigations, gout seems to be more appropriate answer. Yeah. Yes. But before we go ahead, I wanted to check out with this second question as well, so that we can add on some additional information or additional literature. Yes, Ratan, porphyria, yes, it can be included under differential diagnosis. With more information, yes. Even in porphyria, there can be hyperuricemia, that's right. Yeah, but we need additional inputs in order to get back to that diagnosis, okay? So what is the gold standard for gout diagnosis? As I already mentioned, hyperuricemia doesn't always mean gout. There can be even hyperuricemic asymptomatic patients. Then which one do you think you can consider as gold standard for gout diagnosis? Yeah, Eddle's disease also one of the differentials. So is it clinical signs and symptoms as we have seen in this particular context? Or is it the lab analysis of patient's blood again as we have seen in this particular context? Or is it radio imaging like ultrasonography? Or is it MSU crystal identification in synovial fluid? So among the given options, which one do you think is more appropriate answer? Because options A and C, we have seen in this particular context, and we are still saying that, there can be several differential based on given data. We cannot rule out other options, as you mentioned. So which one among the following do you think is a gold standard for gout diagnosis? As majority of you are choosing, yes, option B is right answer. Monosodium urate monohydrate crystal identification in synovial fluid is considered as gold standard for gout diagnosis. To go into detail, like we shed polarized light, and there will be birefringence exhibited by these MSU crystals. There is negative birefringence. Birefringence means nothing but it's a phenomenon of a material. It's an optical property of a material where if you send an incident light, it splits into two rays, ordinary and extraordinary rays. And depending upon the orientation of these ordinary or extraordinary rays to the optical axis, we say that the crystal is either negative birefringence or positively birefringent. So we have those properties which are beyond the scope of discussion of this particular video. But to conclude, monosodium urate monohydrate crystals, MSU crystal identification in synovial fluid is considered as gold standard for gout diagnosis, and they have this property of negative birefringence. I just want you to make a note of this point. When observed through polarized light, you know the difference between unpolarized and polarized light. Polarized light, where you have like the vibrations of waves in one direction. So when you incident polarized light, right, there is negative birefringence being exhibited by these MSU crystals. In fact, this can be used to distinguish gout from pseudo-gout as well. So just keep this point in mind. Along with that, we'll be sharing some additional information in the form of reference materials. You can go through that in e-classes, and you can get back if you need any further clarification. Ratan Singh says MSU will be in urine, not in synovial fluid. I beg to differ, Ratan. According to PubMed Index article, synovial fluid analysis has to be done, arthrosynthesis, and in synovial fluid, detection of monosodium urate crystals is considered to be the gold standard for gout diagnosis. And if you have any information, any standard reference to the statement which you have mentioned, feel free to get back through mail. We'll see. And if any clarification has to be updated, we'll do it because we are open-minded. So according to my PubMed indexed article reference, which is on gout, synovial fluid analysis has to be done. And in that, MSU crystal identification is considered as gold standard. And to briefly summarize information about gout, as you know, gout by now you might have understood that it's a form of disease where there is accumulation of crystals within the joints. That itself is the meaning or definition of gout pathologically. Gout is among the most prevalent etiologies of chronic inflammatory arthritis, characterized by monosodium urate monohydrate crystal deposition in tissues. If you take tophi, for example, there can be deposition of MSU crystals in soft tissues, even in bones, in the form of nodules, as you know. Gout is characterized biochemically by extracellular fluid urate saturation, which is reflected by hyperuricemia in blood, where the serum urate concentration exceeds 6.8 milligrams per deciliter. This 6.8 milligrams per deciliter is the approximate limit of urate solubility. And there are so many clinical manifestations of gout. It can be acute arthritis, chronic arthritis, or tophi, which is also considered as a form of chronic process. But tophi, you can clearly see that the urate crystals are surrounded by granulomatous inflammation. Right? We can go through these additional information a bit later. Now, yes, now I hope it's clear. And regarding the gold standard for gout diagnosis, let me provide you some additional information in regard to this. So synovial fluid analysis. Monosodium urate crystal identification remains the gold standard for gout diagnosis. Gout flare is marked by presence of MSU crystals in synovial fluid obtained from affected joints by direct examination of a fluid sample using polarized light microscopy, as we have discussed prior. And synovial fluid during a gout flare-up, as in this particular context, is yellow in color and cloudier in appearance. If at all there is any infection like sepsis within the joints, then the color of fluid, synovial fluid, varies. It becomes yellow-green, along with microscopic presence of increased blood cell count, indicating a kind of infection. Or else, usually in case of gout, you find yellow-colored synovial fluid with MSU crystals, and it has a cloudier appearance. That's it. That's the take-home message. So as you can see in this particular illustration, so demonstration of MSU crystals via polarized light in your synovial fluid, you can see they're appearing like needle-shaped or long needle-shaped or rod-shaped crystals. So monosodium urate crystal deposition under a polarizing light microscopy has the following presentation. It is described as a rod or long needle-shaped crystals with negative birefringence. Under light microscopy, tophi consists of several zones. Tophi is one of the clinical presentations of gout. As I said, chronic with granulomatous inflammation. So the zones of tophi include a crystalline center surrounding corona zone, surrounded by fibrovascular zone, and various multinucleated giant cells, histiocytes, and plasma cells are found in corona zone. You can find this information in the reference material as such. Okay. Now let's move on to the next question. In fact, this is one of the previously asked questions, the previous need. So guidelines for starting urate-lowering therapy. So you have the following options: frequent gout flares, gout with CKD stage 3 or higher, TOFA's diagnosis on physical examination, past urolithiasis. So on what basis should you start urate-lowering therapy? You have the following options. The patient has option A, would you go for ULT? Or the patient has option B or C or D, would you go for ULT? So what's the guideline or what's the criteria? And also you should understand that in case of gout, gout usually happens either because of excess production of uric acid, hyperuricemia, as you have just seen, or it could be because of compromised excretion of uric acid via kidneys, as in case of chronic kidney disease, right? So it can be two-way, overproduction of uric acid or under excretion of uric acid. Overproduction of uric acid happens because of so many reasons, including infections as well as diet. People are taking certain specific diet, purine-rich diet, like non-vegetarian, in specific the organs like liver or fish, or they even mentioned about alcoholics. Also, they mentioned about sweeteners or the cool drinks as such. So there is certain specific diet called as purine diet. So those who take such purine-rich foods also have this greater propensity to develop gout at a later date. And also there are so many comorbid situations which would complicate and which would predispose to gout, such as diabetes mellitus, hypertension, chronic kidney disease, hyperlipidemia. So all of these conditions can predispose to gout, right? So given the information I've gone through, which of the following options do you think is more appropriate answer? In fact, this was asked in previous NEET entrance a couple of years ago. I'm sure you remember those who have attended previous entrances, or here you go. I think you're all turning out to be smart. Yes, let me review some information related to this urate-lowering therapy. So first and foremost, the clinician should not start with ULT or urate-lowering therapy in patients with asymptomatic hyperuricemia or gout with rare attacks, that is less than one flare per year. It's considered as rare attack. And let me repeat, the clinician should not start urate-lowering therapy in patients with asymptomatic hyperuricemia or gout with rare attacks, that is less than one attack per year. According to American College of Rheumatology, ACR 2012 guidelines, starting urate-lowering therapy is based on the following criteria, as majority of you have rightly chosen. All of the above is right answer. Frequent or disabling gout flares. When I say frequent, it means greater than or equal to 2 per year. Or number 2, gout with chronic kidney disease stage 3 or higher. In fact, my mother is on urate-lowering therapy. She is taking febuxostat, which is a xanthine oxidase inhibitor, right? Just like allopurinol. So patients with CKD stage 3 or higher, we have to go with urate-lowering therapy. TOFUS diagnosis on physical examination or even on imaging, use an ultrasonography or CT. Past ureolithiasis or kidney stone. So all of these have been mentioned as guidelines for starting. All of these or any one of these have been mentioned as guidelines for starting urate-lowering therapy. I hope it's clear. Well done. Do award yourself +4 if you have chosen all the options. Now let's move on to the penultimate question. We're talking about MSU. What does MSU stand for? As I mentioned, monosodium urate monohydrate crystals. So MSU deposition is apparent on ultrasound as hyperechoic enhancement over cartilage, known as option A, double Damaka sign, or option B, double Bonanza sign, option C, double contour sign, option D, double contrast sign. So which one do you think is more appropriate answer? In fact, as I was mentioning about TOFI previously, TOFI are nothing but subcutaneous MSU deposition, MSU crystals deposition forming nodules. And it can happen, this deposition can happen in joints or cartilages, it can happen in soft tissues or even on bones, right? If this MSU deposition is seen on cartilage, what do you call that sign in ultrasonography? So ultrasound reveals a hyperechoic or whitish enhancement over the cartilage, which is also known as double Damaka sign. No one has chosen Damaka sign. You don't like Damakas, you don't like Bonanzas. No one has chosen option A or option B. I really feel sorry for you. Double contour sign, or is it double contrast sign? So which one do you think is more appropriate answer? So ultrasonographic appearance of tophus or MSU crystal deposition over cartilage. Yeah. So first of all, as I was mentioning previously, tophi are subcutaneous depositions of urates that form nodules and can be found in patients with persistent hyperuricemia. Tophus, you come across tophus on physical examination or through some imaging. It's understood that the patient has been suffering with hyperuricemia for quite a long time. And also, as I mentioned, tophi are deposits of MSU crystals encompassing granulomatous inflammation, clearly indicating that it's a chronic situation. So tophi are most often found in periarticular, articular, subcutaneous areas, including cartilage, bone, joints, tendon, skin, rich in proteoglycan. So now coming to the point, imaging. So you use ultrasonography, and as majority of you have rightly chosen, double contrast sign is wrong answer. It is double contour sign. Okay? Don't worry even if you're wrong, because you have learned something today. So let's go through imaging now and simultaneously look into the ultrasonographic image. So monosodium urate deposition will be apparent on ultrasound as hyperechoic enhancement over the cartilage. So as you can clearly see here, deposition of MSU crystals over the cartilage appearing as hyperechoic enhancement over the cartilage, giving you a double layered appearance, also called as double contour sign. You can see the contours, right? Like just like a rainbow. So contours, two contours, double contour sign. I think Sidra is the only person who answered it right. Well done, Sidra. Keep it up. And also Smriti, Shivangi, very good. So you guys award yourself +4, rest of you it is -1. So let's get back to the question once again. MSU deposition, which is apparent on ultrasound as hyperechoic enhancement over the cartilage, is called as double contour sign. Now that you have checked this ultrasonographic image, I'm sure you're never going to get confused or forget about this double contour sign, which is seen in case of gout, right? All clear? Now let's move on to the final question. So this is again one of the questions which was repeated 2 or 3 years prior in NEET entrance. Frontal headache is associated with which of the following drug? Indomethacin, naproxen, ibuprofen, diclofenac. Which one do you think is more appropriate answer? By the way, all the drugs, if you carefully observe, these are NSAIDs, which are first-line drugs in case of acute gout, the pharmacological means or measures. So among the following, one of them has frontal headache as a characteristic and prominent adverse effect. So frontal headache is associated with which of the following drug? Indomethacin, naproxen, ibuprofen, diclofenac. Since it's a previous question, since it's a repetition, I'm sure majority of you will get it right, as you have been getting it right now. So NSAIDs are most effective when therapy is initiated within 48 hours of onset of gout symptoms. NSAIDs are recommended in patients, but not in all patients. It is contraindicated in patients with active duodenal or gastrointestinal ulcers, cardiovascular disease, NSAID allergy, CKD patients, etc. However, it is considered to be the first-line drug to address an acute flare-up of gout. So first-line treatment of gout flares are NSAIDs and also colchicine, including systemic glucocorticosteroids, right? Steroids also are indicated. So if you look into various NSAIDs, indomethacin, dosages and all, it's all available in reference material, we can go through that. But indomethacin is a potent anti-inflammatory with prompt antipyretic action associated with frontal headache, as you all rightly mentioned. I think majority of you have chosen option A. It is highly potent inhibitor of prostaglandin synthesis and suppresses neutrophil motility. In toxic doses, it uncouples oxidative phosphorylation just like aspirin, and it has several adverse effects such as increased incidence of gastrointestinal and CNS effects, Gastric irritation, nausea, anorexia, GI bleeding, and diarrhea are prominent with indomethacin. And frontal headache is very common with dizziness, ataxia, mental confusion, hallucination, depression, and psychosis. So, in the process, I've gone through some of the important features of indomethacin, which is an NSAID, right? So, frontal headache is associated with indomethacin, as majority of you have rightly chosen. Award yourself +4. Now, you can present your scores. Out of 20, what's the maximum score you have achieved? Or what's the minimum score? Let's look into your scores now. Homework questions, you have the following homework questions. What is sausage dessert? Sausage dessert, something like an eatery. So what is this sausage dessert? Second question, what is DRESS, DRESS syndrome? And third, aspirin is not used to treat gout flare. Why? Justify. Statement is true. So give me an explanation, justify the statement. Sausage dessert, DRESS syndrome, aspirin not indicated or used for treating gout flare. So these are your homework questions for this session, right? So try solving them and get back through mail for the key. Yeah, brushing of teeth, as you can see here. It should remind you of the task of consistency. So Payal has secured 12 marks, very good. Sidra, 20 plus. So what does that plus stand for? Very good, Sidra. It's definitely a challenging session, and scoring 20 upon 20 is no easy task. Well done. Very good, Payal, 12 marks. So whatever mistakes you have done, I'm sure you're not going to repeat those mistakes if at all you have questions along these lines in your final exam. And even most importantly, keeping this course aside, have you learned something from this session? Did you enjoy the process? The answer is yes. Then you are on right path with right orientation, right? So as I mentioned prior at the beginning of this discussion, consistency is something which really matters the most. And the only difference which I see personally between a successful person and a failure is the consistency factor. Consistency comes only when one is dedicated towards the task at hand. Consistency comes only one is conscious about what he or she is doing. Consistency happens only because of the fact that the person is willing to take up anything at any time in order to reach his or her goals. It merely reflects one's enthusiasm and one's dedication, as simple as that. So consistency happens because of so many positive factors which come with right orientation. Just remember this simple exercise of brushing of teeth. You'll not feel stressful. You'll not feel that as a burdensome work. And there is nothing like you'll go wrong in it. And the only, all that happens with brushing is so many positive outputs, including enhanced oral health, lack of halitosis, and because of which, again, you're able to eat well, digest well. So it's all like a ripple effect, isn't it? So that's how actually things happen in real life as well. If you take care of just one aspect consistently, it can be preparation, it can be a personal hygiene, it can be anything. If you take up one minor aspect in a consistent manner, that itself will have a ripple effect on all the other activities of your day. Just take note of it. So you have any queries, you need any clarification, you need any further assistance regarding gout or regarding anything in general, feel free to get back through mail 24/7. And before I conclude, I think I'm missing some comments. Let me go through your comments and then I'll conclude the session. Sidra, I appreciate your feedback. Thank you. Yeah, I think I've seen one of the comments. Yes. Ratan says, kindly give us a marathon session on picture-based MCQs. Definitely, Ratan. That's in fact a very good idea. I'm noting it right now. So we'll definitely plan to incorporate one marathon session exclusively on image-based questions or just images, okay? We'll definitely consider Ratan. Yeah, and also first metatarsal, yeah, gout. One of the most common findings or common presentation, as Ratan already mentioned, and also we try to highlight in the clinical image, is the involvement of first metatarsophalangeal joint, which is seen in case of gout. So gout flare happens in one particular joint, or it can happen simultaneously in several joints, that is monoarticular or polyarticular. The most commonly involved joint is the first metatarsophalangeal joint. So we try to present that information in this particular context. You can make a note of that point. Ratan, I really appreciate your feedback. Rishikesh, Sidra, Ignatius, Shubhangi, Kishore, Ritu, Tejashvi, Sai Rajat, Payal, Tanmay, Vinita, Arshi. Hi, very good evening. Hi, Nagmani. Hi, Priyanshi. Hi, Saurabh. Hi, Shika. Bhavna, Shailaja. Hi. Ignatius, yes. Smriti, Shivangi. So we actually have two piles attending this live session. I reckon. Ankita. Yes, pile Paul and pile 2. You're most welcome, and it's my pleasure interacting with you all. I'll see you again tomorrow at 9:30 p.m. in our next case-based live discussion. So wish you all the best. Love you all. Keep smiling and keep giving your best. Good night.